section, we're going to talk about non-anion gap metabolic acidosis. A mnemonic for this is ACCRUD, ACCRUED. And you'll see here that each of those stand for something, with acid infusion, such as with normal saline, compensation for respiratory alkalosis, carbonic anhydrase inhibitors, such as acetazolamide, renal tubular acidosis, the one that we're going to talk about primarily today, ureteral division, extra alimentation or hyperalimentation, or diarrhea being some of the major causes. Unlike in the previous section, there's not a lot of laboratory values we use to differentiate between these types. Usually you can use the history of physical illness or medication history to help differentiate. The one with the most differentiations that you may need to do clinically is the renal tubular acidosis, which is the one that we're going to talk about primarily today. So renal tubular acidosis is the inability of renal tubules to retain bicarbonate or to secrete hydrogen ions. It can be both, but usually it's in the setting of somebody who does not have reduced GFR or may have only mildly reduced GFR. You will see that there are 4 different types, but we're really only going to talk about the 3 major types today, which would be 1, 2, and 4. So let's start out with type 1. Type 1 renal tubular acidosis is also known as distal renal tubular acidosis or classic distal renal tubular acidosis. And this is a defect in acid secretion in the distal convalescent tubule. And it can be due to some of these less common disease states such as Sjogren's syndrome, lupus, sickle cell disease, or more commonly with chronic liver disease. There are some drug-associated causes too. The big thing you want to remember is that it is associated with hypokalemia, and this can be secondary to hyperaldosteronism and having impairs in the proton potassium ATPase. Patients may have tube renal stones, also known as hypercalciuria or nephrocalcitosis. This is overall treated with low-dose bicarbonate versus type 2, which is treated with higher doses of bicarbonate. You do not need to know the specific doses, just knowing that it's higher versus lower doses is all I need. So this is proximal renal tubular acidosis, and this is a defect in bicarbonate reabsorption in the proximal tubule. Type 1's in the distal, type 2's in the proximal tubule. And this can be a part of other types of proximal tubular dysfunctions. Fanconi syndrome is a very rare but serious side effect to some HIV medications that causes literally your proton pumps to just turn around and start, instead of excreting acid, to retain acid. It also can be due to multiple myeloma, nephrotic syndrome, or even toxins such as lead, mercury, or tetracyclines. A drug that causes proximal tubular renal tubular acidosis is carbonic anhydrase inhibitors. This, like type 1, is associated with hypokalemia, and again is secondary to hyperaldosteronism and salt wasting. This requires a much higher dose of bicarbonate compared to type 1, as I mentioned before. Finally, you have type 4. Type 4, the biggest difference between type 4 and the other types of renal tubular acidosis is that this one is associated with a hyperkalemia. And so this is a distal renal tubular acidosis as well. And it's associated not with a problem with your renal tubules, such as the proximal or distal convoluted tubule, but aldosterone resistance or deficiencies. There are some disease states that may cause this, but most importantly, the medications. Any medication that affects the RAS system, such as an ACE inhibitor, an ARB, NSAIDs, beta blockers, or aldosterone antagonists, may cause a type 4 renal tubular acidosis. They also drugs that may inhibit renal potassium absorption, such as trimethylprim, is also a cause. You manage this one differently than you do the other agents. What you want to do is you want to make sure that you correct the hyperkalemia. And then also you want to make sure that you try to discontinue any causative agents, and you may need to include a fludrocortisone or diuretic to treat it. Bicarbonate is used in selective individuals, but most commonly bicarbonate is used in the type 1 and type 2 comparatively to the type 4. You'll see here's a little bit of an easy chart that I want you guys to know. So the base defect in type 1 is a decrease in distal affectation versus type 2, which is a decrease in bicarbonate reabsorption. Type 4 again is aldosterone resistance or deficiency, and it can be secondary to any drug that affects the renal angiotensin aldosterone system or the RAS system. You'll see here that you have type 1 and type 2 causing hypocalcemia versus type 4 causing high potassiums. So this is an easy way to determine whether or not you have a type 1 or type 2 versus type 4. The way you can distinguish between type 1 and type 2 is based off your urine pH. The urine pH would be much higher in the type 1 because you're not having as much distal acidification versus type 4, which is decreasing your bicarbonate reabsorption. Type 2, which you're decreasing your bicarbonate reabsorption. You'll see the treatments down here with a higher dose, and that's all I need you to know, of bicarbonate in the type 2 versus type 1. You will want to DC the causative agent, correct the hyperkalemia, and give fluorocortisol in patients with type 4. Here's a little bit of going back to our flow chart. If we do have a metabolic acidosis, you want to calculate your anion gap. If it's less than 17, this is a non-anion gap. So if you know that there's a source of acid, such as normal saline or hyperalimentation, stop or change that therapy. If you have a high bicarbonate loss, whether that be diarrhea or ureteral diversion, you can control the cause using pharmacology or surgery. And then finally, if you do know that there's neither of these, high bicarbonate losses or acid, consider renal tubular acidosis. If hyperkalemia is present, then it's type 4. If there's hypokalemia, you can just look at the urine pH. If it's high, that's renal tubular acidosis type 1. If it's low, it's type 2.